Good afternoon. Thank you for tuning in to today's Wisconsin Health News virtual panel series event on addressing health inequities beyond COVID-19. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thank you to our esteemed panelists for joining us today. I am thrilled to introduce Theresa Jones, Vice President of Inclusion, Diversity, and Equity for Children's Wisconsin, Kevin Moore, CEO of UnitedHealthcare Community Plan of Wisconsin, Lisa Peyton-Caire, President of the Foundation for Black Women's Wellness, Laura Waldvogel, CEO of Family Health La Clinica, and T.R. Williams, Assistant Deputy Secretary for the Department of Health Services. Thank you all for sharing some of your valuable time with us today. Before we get started, I want to make sure we thank Badger Bay Management for hosting today's virtual event in partnership with Wisconsin Health News. And thank you so much to our generous sponsors of the Wisconsin Health News panel series. These important and valuable discussions truly would not be possible without their support. So a huge thank you to AARP Wisconsin, Ascension Wisconsin, Advocate Aurora Health, Group Health Cooperative of South Central Wisconsin, Husch Blackwell, Marshfield Clinic Health System, Wisconsin Medical Society, and WPS Health Insurance. Wisconsin Health News is a nonpartisan, independent online news service. In addition to hosting events like these, we also publish a daily email newsletter. If you are not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up through the event evaluation, which we'll send out after today's event. Or you can also sign up on our website at wisconsinhealthnews.com. And an extra thanks today to Advocate Aurora, today's featured sponsor. We are very grateful for their longstanding support of this event series. Here to say a few words today is Drew Bhattacharya, Vice President of Diversity, Equity, and Inclusion for Advocate Aurora Health.
Thanks for the opportunity for being here with you. I'll be brief. Health equity is about eradicating, not just acknowledging unjust disparities. And so we're really trying to do a better effort all around in extending quality care that's accessible, that's affordable, and that's acceptable. It's not accessible if we don't have a ride or some means of transportation. It's not affordable if we have to choose between care and putting food on the table. It's certainly not acceptable if we can't speak English and are denied interpreter services. So if we're really in this together, we have to respect our collective duty towards one another. So everyone has that opportunity to be healthy and to live well. Equity really requires us to be mindful of the historical context of our policies and practices, because they have frankly caused harm to some more than others. And our aspirations aren't just to do better, but to do right. So we want operations, that are standardized, not just on paper, but through which we can hold each other accountable. We want to see transparency. We want to see integrity. We want to see trust. These are all key factors in really advancing equity beyond COVID-19. So this kind of care, this kind of caring is truly courageous. And because all of us have either personally or professionally encountered less in our own lives, we want to be intentional in our efforts. So today we're here to welcome all of our esteemed panelists as subject matter experts who can help us navigate today's challenges against the backdrop of all that we've experienced over the past year. And so we want to welcome all of you for who you are, for what you do, and extremely grateful for all that you're doing. So, thank you for joining us. Thank you, Tim, for you and your team for coordinating this, and let's do better together.
Thank you so much, Drew. Thanks for those great words to get us started. And thanks for all the work that you are doing at Advocate Aurora Health on this topic. And thanks again to Advocate Aurora Health for all of your generous support to make these important discussions possible. As has been well reported, and as Drew has highlighted, COVID-19 has really shined a spotlight on long-standing health disparities in Wisconsin and around the country. And in Wisconsin, that spotlight was extra bright, as the gaps are really among the worst in the country. Black babies in Wisconsin are 3 times less likely to reach their first birthday than white babies, and Black moms are 5 times more likely to die from pregnancy than white moms in Wisconsin. So what's at the root cause of these disparities? And as the COVID-19 pandemic recedes, what can be done to ensure that as we come out of this global health crisis, that we can begin to reshape how we deliver care to our state's most vulnerable residents? So we have a wonderful lineup of panelists with us today to learn more, and I'm just going to dive right into the questions. And Lisa, let's start with you. This is an especially personal issue for you as you lost your mother to heart disease in her mid-60s. How are our health inequities still impacting Black women today in Wisconsin? And what do you think is the root cause of these inequities?
As you said, Tim, and as Drew said in his opening remarks, and again, thank you all for the opportunity to be here. We are sitting in what I call the center, the hotbed of disparity in Wisconsin and also in the Midwest. So when we think about Black women's health, we are dealing with some of the gravest, deepest, and most persistent health and quality of life disparities in the country. And that has really been unmitigated and uninterrupted for the last 30 years that we've been measuring and disaggregating data. And we all know the data, right? There's no secret around what those outcomes look like in terms of mortality, morbidity. You spoke to the statistics around maternal health outcomes, first in the nation here in Wisconsin for Black infant mortality, 5 times greater maternal mortality rate. And one of the most stark pieces of data around Black women is that Wisconsin is the only state in the United States where the life expectancy of Black women is declining. And the gap between Black women and white women's life expectancy is widening. Again, the only state out of 50 where that trend is emerging and emerging consistently. And that is quite alarming because we are a state with so many resources, with so much care, right? We outrank many states in level of healthcare coverage, levels of healthcare access for Black women, but yet we continue to trail the nation in healthcare outcomes, despite excellent care that's highly ranked nationally and internationally, and despite having world-ranked institutions of higher education that research these issues ad nauseum, day by day. So we're in the center of a crisis that has not changed. And this conversation is so urgent right now because we've got to change that narrative. And that's the work of the Foundation for Black Women's Wellness and many of us on this call, despite the communities that we are working with. But we want to call attention to everyone of the particular circumstances of Black women and babies and their families that are really, really vulnerable in ways that have been unchanged for decades. So it's really alarming. When we speak about root causes, we often attribute the outcomes of Black women and their families to individual behaviors, to community dysfunctions, this deficit model understanding and limited to looking at people's personal health behaviors. It's really systemic and structural. And the roots are really plain spokenly in racism and classism and how that stratifies opportunity and access in our country, which is rooted in our historical context. As Drew said, from the origins of our nation, we've struggled to create an environment where opportunity and access looks the same for everyone. And as we look at that hierarchy that we've created as a nation and where people fall in that hierarchy, Black women and families are on the bottom of that hierarchy of opportunity and access, along with Indigenous, Latinx, low-income folks of all backgrounds. So we have reckoning to do in our nation to resolve this if we're really serious about changing what equity looks like in America.
Thank you, Lisa. Laura, your health center serves a majority Latinx population in central Wisconsin. How has the COVID-19 pandemic impacted your patients? What type of inequities have been further exposed over the past year and a half?
Yeah, thank you. Thank you for the question and thank you for the opportunity to talk about this. So we serve a primarily rural service area in central Wisconsin, but we also have a second and equally important charge, and that is as a migrant health center serving the entire state of Wisconsin's migrant and seasonal agricultural workers. And the issues that we have seen, there are some similarities and then there are some differences. For the rural population, the traditional things like transportation, access to broadband, being able to get into specialty care, COVID exacerbated those types of things. And in some ways, the divide widened. For the migrant and seasonal farm worker population, our team stood up programming immediately to engage in risk mitigation strategies last year. And that's because the migrant and seasonal farm workers in this state that are working so hard to ensure that produce makes it to our tables are at higher risk because of living and working conditions. So things like testing, education, and now this year vaccines But we have to meet those workers where they're at because they work very long hours and they do not have transportation, and language is a barrier. So we are literally traveling with a mobile unit or a mobile team throughout the state, delivering those services and delivering primary care services. So in some regards, the issues that we have seen with both populations have widened, but in others, in particular with the migrant and seasonal farm workers, we have seen a coming together of a number of groups that serve the farm workers in order to work together. We've always collaborated, but the level of collaboration has greatly increased from the state of Wisconsin to United Migrant Opportunity Services, Family Health of Clinica, and workers, other worker advocacy groups, employers themselves, working together to figure out how we can best meet the needs of this. It's not even essential, it's imperative that we take care of this population so that they can attend to what they attend to for us.
Thanks, Laura. Kevin, the Medicaid rolls in Wisconsin have been growing every month since December of 2019. What type of inequities have you seen further highlighted over the past year and a half amongst Medicaid members?
Yeah, thanks, Tim, and thanks for the opportunity. I'll even take a little bit of a step further and say that while we've seen the rolls increase over the last year and a half, we've also seen utilization of services, obviously, because access has become a bigger and bigger issue as providers have been closed. And then that just has manifested itself in kind of whether it be fear or just a additional disjointedness and disconnected with the delivery system. So in some regards, I think as we're moving out of 2020, 20 and 21 and thinking about what life after COVID looks like, we want to make sure that we're learning from it, but we're also realizing the magnification. Lisa, I think, brought up a really important point that this has been a long-term, you said 30 years, multi-decade approach. And I think for us is how are we looking at investing in our community? How are we investing in our members? How are we investing in our providers so that it's not just the thought of, well, here is a chunk of cash, we're going to move forward. We want to make sure that we are partnering with anchor institutions in the community so that we're kind of we're trying to reverse the tide of 30 years of whether it be distrust in the system. And especially now with COVID, that there's been a magnification and an amplification of that distrust. So we're not saying as a payer, we actually look at it as an opportunity to invest in our communities, but doing it from a partnership role where it's not necessarily about we're UnitedHealthcare. It's more of we're invested, whether it be from my staff, my members, we're invested in this community. And so how do we make those investments so that maybe it's not just about access? We talked a lot about transportation. We talk about education. We talk about health literacy. A lot of that can be done outside of even the four walls of our clinical partners or in partnership with our clinical partners to get it into the community. That's why, just as we look at how we're making investments, we're making investments in barbershops. We're making investments in churches, primarily because we recognize that those messengers can be very important on mitigating distrust that has been decades long in the making. And so that takes a little bit different mindset, though. We have to have a longer horizon than 2022. And that's what we want to do here at United. We're looking at decades moving forward to change that trajectory.
Thanks, Kevin. TR, COVID-19 revealed the health inequities, further revealed the health inequities plaguing our society. But COVID-19 vaccine take-up, which remains lower among communities of color, is also further revealing the deep mistrust, and it's been mentioned a couple times already today, the deep mistrust that still exists of the health community. Can you talk a little bit more about that, about how that is impacting COVID-19 vaccination take-up, but also impacting better health outcomes?
That's a great question. I'm happy to be here. Thank you for having me here. I am having a little bit of the internet connection, so I may be a little delayed. As others have said, what we have seen in COVID-19 has been exacerbation of the health inequities and disparities that have existed That's not new to public health experts, and is certainly not new to those who are experiencing those health inequities and disparities. It's not news to them. Social determinants of health is not a new term to them. That combination of those words in that order may be new to some of us, but it's certainly not new to those who are experiencing the issues. And so as we look at COVID-19 and the impact that's had on disparities, we're seeing the access to quality healthcare. We're seeing the having safe, affordable housing. We're seeing, being able to have employment, and what you are all parts of what has existed before COVID, but we're seeing it in the rollout of the rates of COVID test, of COVID, hospitals of COVID deaths. And so in recognizing this reality and in leaning into what we know, the data is showing us and what has been experienced as we consider the historic and institutional, and I should say, when I say institutional, I'm talking about systemic set of policies, practices that are functional to a belief system. When I use institutional, when we know the realities of those root causes that have already been addressed on this panel, that is the way in which we have to COVID response and recovery in order to right size what we're talking about and what folks are dealing with. So that means us taking extra efforts, especially early on in our vaccine rollout, to recognize those health providers that were particularly in areas and for those who were most impacted by COVID, making sure that they have enough vaccine, getting the vaccine out to them. It also means our minority health, which we give about $50,000 each to different community organizations doing the work, leaning on the relationships and the work that they've already done and connecting to them when it comes to education early on in the pandemic for the response, and as it relates to the recovery and vaccines. Also working with organizations like Family Health, like Clinica, our Asian and Disability Resource Centers, all of our community health centers are federally qualified health centers, United Way 211, all of these established organizations who are in the work, who have this currency with populations and demographics that are experiencing these disparities, working with them in our rollout of the response and the recovery to COVID.
Thank you, TR. Theresa, statewide, more than 60% of adults have received at least one shot of COVID-19 vaccine, but only 38% of Black adults have received their first dose. What more do you think that the state or other community health partners could do to reach communities of color where vaccination take-up is lower?
Thanks, Tim, and thanks for having me here today as well. It was interesting. Yesterday, I was actually in a meeting with Sherman Phoenix, an organization here in Milwaukee, and we were talking about how we could reach the African-American population. And I think our traditional methods of trying to reach people have to change. And so they were saying, you know what? It's social media. People come here, they frequent the restaurants and the barbershops and the beauty shops and, all of the services that were under that roof. Let each of us help you with our customers get access. These are things that healthcare systems certainly might not have thought about in the past, but that we have to change our approach and get closer and provide care closer. In Milwaukee, I'm seeing we're knocking on doors and talking to people at their home, in their environment. So getting that care closer to home. We were brainstorming ideas about having just fun events and having our physicians at those events to be able to talk about COVID vaccine. So looking at creative ways, there's huge trust issues in the African-American community. And we're talking about kids now, adults are having struggles trying to get vaccines. Think about now what they're thinking about as it relates to their children. That makes it even harder. So we've got to find ways to get closer to people. And I love the trusted partner concept, because that really is another avenue of getting to people that people trust, whether it's in the church or, like we were just mentioning, in the barbershop, in the beauty shop, wherever that might be, that might help. But it's using those non-traditional approaches to really bring information and education. And so the event that we were planning would bring both, would bring not only the physicians and the education, but if people then want, they could step outside and get the vaccine. So trying to connect all those dots. You're in a place that you're comfortable with, you're coming there for food and fun, you're going to get a little education while you're there, and then you can also get the vaccine. So making it really easy for people to be able to access those kinds of services.
Thank you. Lisa, what more do you think can be done to overcome some of these longstanding trust issues and also reach communities who for many legit reasons are not trustful of the medical community with COVID-19 vaccines?
You know, I think our panelists have answered that as well as it can be answered. It really does sit with trust. It really does sit with education, awareness, with quality information, information that's not conflicting, and information that really does confront that history of medical negligence and medical impropriety that our communities have endured, not just long ago, but even recently. You know, within these last few decades, our communities can point to situations where our health has really been taken advantage of, experimentally and otherwise. And that's very front and center and top of mind for communities of color all the time. It has not changed. And because of the very recent, present, and continuing inequities in care, quality of care, the biases and racism that we experience in the delivery of care, how we're treated differently, and how our conditions are assessed or how our treatment is received, the level and pace and speed and quality of that, there is just deep distrust. And particularly if you talk about, you know, an immunization, a vaccination that's coming from what people see as the federal government, there's real emotions around that. So addressing that issue of trust is a complex one, and it can't be changed in a day. You know, we're moving very quickly out of necessity and working to, you know, abate COVID, to eliminate the threat. We're moving at a speed of light that really doesn't match the long historical, you know, all of the time that it has taken to develop these this deep chasm in our communities. And so I think in our methods and our communication, we have to name that, outwardly name that, and do the relationship development and the trust building in the community. It has to be prioritized as much as prioritizing the setup of the clinics and the vaccination stations. It has to be done in lockstep. Our method has been to provide consistent education, to bring in healthcare providers, to talk about and engage directly with community where they can ask all their questions about the vaccines, the different types, what we've heard about potential side effects and the benefits, and of course, obviously, the overall purpose of working together to overcome COVID. And those efforts have to intensify and be continuous until which time we reach a space where we achieve the results that we want.
Laura, in a lot of communities, providers don't always look like their patients. What impact does this have, not only on mistrust in the healthcare system, but in quality of care and outcomes?
So absolutely, and in particular in rural environments, even just recruiting providers period into a rural environment is challenging. Recruiting all staff into a rural environment can be challenging, and yet it is critically important that that intentional effort is made to recruit and retain providers that represent the patients that we are serving, that speak the language of the patients that we are serving. And some of those efforts include taking a look at, certainly you can't look at hiring requirements of a physician. You must be a qualified physician to provide care. But in terms of some of the educational requirements that in the past perhaps were given more credence than lived experience, making sure that your workforce is representing the patients that you are serving, making sure that you are intentional in your efforts to hire those that represent appropriately those that you are serving. So in some regards, perhaps it's scholarship opportunities, long-term investments in your workforce, things that you're, as Lisa was saying earlier, you're not going to see it overnight, but you're going to invest in it over the long term and continue those efforts over time.
Theresa, what more do you think can be done to build a more diverse healthcare workforce and more diverse healthcare leadership?
It definitely is about being intentional about it as well. And then in particular, setting some metrics so you can measure your progress. I think it has to start much earlier, and you have to engage the staff that you have to help bring people along. And so we're looking at opportunities for mentoring internally, looking at opportunities as we go out in the community and into the schools for mentoring and development, and then creating those workforce development programs in areas where we see some huge disparity as well. So it's kind of a collective effort. It's a number of things. It's not just one thing,
right.
But I think that metric to measure the impact that you're having so that you can really figure out, are we making progress here? Is it going to net us where we want to be? Because sometimes, if you don't put those metrics in place, you really don't have a good sense of whether or not you're having the impact that you want. I also think too, in the meantime, because I don't think we always talk about in the meantime, when we know we don't have a workforce that mirrors a population, we have to work on cultural competence with those providers we do have. That's so important because as I think it was Lisa that mentioned, it's going to take a little while. It doesn't happen overnight. So we've got to certainly work on that as well.
Thank you, Theresa. So I want to shift gears a little bit now and talk a little bit more about some of the work that is being done to address health inequities. Kevin, you've already talked about some of the stuff United is doing. We had a similar panel like this a couple years ago, and your predecessor talked a lot about the work that United has done around housing. I wonder if you could talk just a little bit more about that and the impact that has had and you think could have on addressing health inequities, and maybe some results you've seen with that at this point.
Yeah, thanks, Tim. And I think it really rolls up into a common thread that we've talked about through all of this, which is, I think, TR, I think you were the one that said, it's the new social determinants of health, whatever you call it right now. How are people meeting that 80% that is necessary to be able to get to the 20% so that the utilization and the outcomes are really where they need to go. So yes, we've done a number of initiatives across the country and here in Wisconsin related to housing, specifically around individuals that are chronically homeless. And yes, we've seen some great results out of that, primarily because in a combination of the housing, we've been able to wrap around behavioral health services. We've been able to support them with the stuff that we may think on a day in and day out basis is commonplace, but just being able to get a vital record to be able to make sure that you're able to get a lease. Even now with COVID, it's even a little bit more challenging to get that vital record, and it's a little bit more costly. So we've definitely had that experience, but we're also now trying to figure, how do we scale this? How do we get this up so that as a Medicaid managed care plan have more tools in our toolbox, if you will, to mitigate some of these other issues? We can look at not just non-emergency medical transportation, but non-emergent transportation. We've had great partners at the state with Director Jones and the Medicaid program about even looking at Medicaid outside the walls of just the traditional clinical delivery model so that we are able to pay for some of these other services. And so there's great opportunity, I think, but the challenge also is being able to understand, where do we start? And so, yes, we've been able to do pilots. Now we're looking at, how do we scale? How do we start to think a little bit bigger? And then ultimately, I think it's really a question of, how do you start to get upstream? How do you start moving from being reactive to proactive? How do you look at it through the lens of rather than us being focused on chronic homelessness, which I think is something as a community we are all vested in, but how do you look at eviction prevention, or how do you start to look at things that may be a little bit more challenging to quantify through your traditional return on investment math, but really is what is going to allow for true deep partnerships with anchor institutions in the community to really get at what we've all been talking about, which is how do you get rid of distrust? It's through being there and being present and having interpersonal partnerships and relationships where people can trust you on. So again, I think the whole concept of SDOH is really important. We've had some great experiences in the past, but now we're really vested in how do we broaden this? And again, Milwaukee, Racine, Kenosha versus Madison versus the rural parts, they're all a little bit different, but how do we get those resources and align those resources for the best of our members and our communities is really what our focus is moving forward.
And Kevin, as we talk about moving forward and moving more upstream, what kind of more broadly do you see as the insurer's role, I mean, in this kind of going forward?
Yeah, I think it's an important part. I mean, as traditionally as a payer, obviously we want to make sure that we are providing education to not only providers, but to members. We talked a little bit about cultural competency. There's a lot of work going on around cultural concordance, which is kind of this concept of aligning patients with providers that are culturally aligned. There's some great research coming out of Minnesota where they're seeing better outcomes based off of Black moms engaging with Black providers or Black OBs. There's some great outcomes there that I think both nationally and also in Wisconsin we can learn from. And so how do we get that information to our members? How do we then also look at investments differently? And I'm not only talking about treasure, I'm talking about time. I think for us, I'll use COVID as an example of what we're looking at. We want to make sure that we're engaging our members, but rather than do a blanket approach, we are resourcing live calls from our health plan staff. They're doing this off the side of their desk because they're just committed to over 2,300 people in specific zip codes in Milwaukee to make sure that we've got a person on the phone to do two things. A, do you have any questions? How can we help mitigate those questions? And if we're able to answer those and they are now motivated, how do we actually get them into an appointment? And I think it's right now we're in the throes of COVID and mitigating and getting vaccines. But I'm thinking now, how does that relate to kiddos when we start thinking about health check? How does that start thinking upstream on the next issue? Because we're so focused on what we need to with COVID. But now when kids go back to school, what did we learn? What can we start to do differently there so that the kiddos are getting the shots that they need so that we can then mitigate, I don't want to say public health emergency. I think we're all fatigued from that phrase, but how do we start to learn from that so that we're doing things differently as a health plan? And really it's just about building relationships and looking at it through the lens of race and looking through the lens of disparity.
Thanks, Kevin. TR, the Department of Health Services recently announced that they're creating an Office of Health Equity. Can you just briefly talk about what the goal of this office will be and where things are in setting this up?
I would love to talk about it. I don't know if it'll be brief though, Tim. I finally figured out Blue's Clues. I was struggling with my
I know you can do your best.
And I'm better now. There we go. So I am very excited about the Office of Health Equity. I think in all of the different ways in which I mentioned what the Department of Health Services has been doing as it relates to COVID response and recovery, when we look at what the governor's office has mandated of his administration from day one when it comes to equity, the Office of Health Equity in the Department of Health Services, to me, is the personification of that work in trying to create a strategic and stable, or I should say a strategic and sustainable way for all of these efforts that are coming. So that office will have a director who will also have an external stakeholder liaison or supervisor. I think that part is very important when we talk about, you know, these root causes of structure and institution and history. Part of what that has meant is that those who are most impacted are not at the seat at the table, or they're not engaged. And so when you're looking at a state public health department to do the work, there is a history certainly there of departments of health services and human services across the nation of being a result of change that has happened, right? But you still are looking at a bureaucratic state system. And so that external stakeholder engagement, what's already been said about trusted partners, or those, as I say, are currency already in those communities that can be tied to the work that we're doing, all of that is going to be able to have a space to sort of live and for that work to happen in the Office of Health Equity. And certainly not that that has not happened in DHS through our minority health program, through our Office of Policy, policy alignment, and in other ways. But this is where this focus is specifically on health equity, and it's attached to the Secretary's office. So it's also in that space of positioning of leadership.
And so one of the charges of the office is to propose policy. What types of policy could you see the office spearheading to address health inequities?
Yes, I want to balance the room for whoever that director would be and their vision of it, and certainly not sort of filling in that seat based on already what DHS has in mind. But as a racially marked woman who's a Wisconsinite myself, I would imagine that those policies will address access to healthcare in urban and rural settings, because oftentimes when we are talking about racial or ethnic minorities, we are putting them, visualizing them in one particular place in Wisconsin, which I think Laura being on this panel is great, is not the truth, right? And so when we're talking about access to quality healthcare, I think about Medicaid, I think about transportation, I think about policies that are focused less on the tracking if people are doing everything right, with is this presumption that folks are cheating the system, and more of a focus on what is the need and how do we most efficiently and effectively meet that need. Which is why what the collective panel has shared about positioning these inequities and disparities, not as a result of individual choice, randomness, or the invisible hand, but rather being the result of a systemic institution with intentional policy decisions when it comes to where people live, where they work, who owns land, who works land. Being very cognizant of those realities, this policy then would need to interject in understanding that this is not that people of color or people of low income status do not value their lives or do not value being healthy or well, and that they are making poor decisions, and thus this is a result of their individual choices, but linking policy to address how they've been intentionally forgotten or intentionally harmed in our system over the history of the United States at its inception.
Thank you, TR. Theresa, the Milwaukee Healthcare Partnership has somewhat recently launched a Health Equity Council, which I know you are part of. Can you briefly talk a little bit about what this council is involved in and its goal?
Yeah, as an individual health system, you can certainly influence your members, but the great thing about the Milwaukee Healthcare Partnership is that it's brought together health systems and the FQHCs to really look at how we can impact the community. And so we've been sharing best practices, looking at how we're approaching different aspects of healthcare, really pooling our resources and kind of saying, what are you doing and what are you doing over here, and how can we really make that work? We're learning from one another, and I think the outcome of that initial work will be that we'll develop some specific strategies on how we can really impact the community. So that collaboration and bringing together all folks that are working together around health and doing work on health equity is just so important at that time. Many issues. Milwaukee Healthcare Partnership is helping us look at some of the things around issues around violence, and we're talking about food insecurity and many of those social determinants of health. So it's great for, I've been in healthcare for many years, and we've worked very siloed, but now we're able to kind of come together and really talk about how those things can really be impacted collectively for the community, which I think is really great.
And Theresa, you are also a member, I understand, of the Speaker's Task Force on Racial Disparities. What is the task force doing, or what does it plan to do around healthcare disparities?
Yeah, there are a few different areas that we've looked at. It's been mostly around racial disparities. And so certainly we've been doing some discussions around looking at some of the same issues we're talking about, whether it is looking at a more diverse workforce, that whole alignment between teachers of color and students of color, and what impact that could have in the school systems, looking at opportunities to provide more funding for people who are trying to get education as well. We know there's a teacher shortage, but we certainly need more more teachers of color. So how do we bridge that gap, and how do we help people earlier in their career? There are some other task force that are working on policing reform and some of those kinds of things. But the specific area that we've been focused on has been on the educational aspect as well.
Thank you, Theresa. Lisa, you are a member of the Governor's Health Equity Council. Can you just briefly talk about what that council is doing?
Well, it's a powerful thing to have an administration that recognizes the need to have a body at that level of influence in our state to really inform our state's thinking and how it structures and shapes its internal processes and policies and practices across our state through a lens of equity. And that really is the purpose of the Governor's Health Equity Council, myself, and there are numerous numbers of people on the council representing broad, diverse communities across our state. So every corner of our state is represented in that body. Deliberate efforts were undertaken to ensure that that representation of every Wisconsinite is on that council. And we're really working to build a blueprint for Wisconsin to really realize and co-create equitable conditions for every member of our state. And through a broad social and structural determinants of health lens, connecting the dots, as our governor often says, between health, wealth, economics, education, justice, because we know all of those areas impact the health and well-being of every member of our state. And we cannot talk about health and health equity in and of itself, because we know it is driven by, shaped by, and influenced by all those other pieces. So it really is a broad body of work with folks bringing different perspectives and level of experience, mapping out a new direction for our state that really gets us to the place and space that we need to be as a leader and not a trailer in health equity, because we know we have that potential as a state.
So Lisa, you've talked about in previous interviews the fact that doing more to address social determinants of health isn't necessarily going to erase this glaring gap in health outcomes. In other words, a Black woman making $150,000 a year, living in a nice house, is still probably going to face worse health outcomes than her white counterpart. Can you just talk more about that? Why is that?
You know, it really comes down to what we've said throughout this call collectively with all of our panelists. At the root of the disparities that we see are not dynamics of individuals. They are structured, socially constructed experiences. And Black women, despite despite income, education level, zip code, or any of those other non-protective factors that we've come to learn are non-protective in terms of our health outcomes, we experience healthcare the same, no matter, if we have pre-GED or postdoctoral level education. And that signifies the collective experience of Black women of experiencing racism and structural inequalities in the ways we are perceived and the way our treatment plays out, in the clinical and healthcare setting. We talked about bias, we talked about cultural competency and cultural congruence and all those things that we haven't really achieved in our nation yet, in our healthcare system. And it really has a life or death impact on the individual and collective health experiences of Black women, Black children, Black men. If we look at the data across our state for Black family members, it's the same, outcome, regardless of whether you're talking about women, men, babies, young children. And so we have to confront that powerful element of structural racism and inequality is not a respecter of class or all the things that we're taught and told that if we do and go achieve and move ourselves up the ranks of our bootstraps and get to a better positioning, that this will eliminate all of our challenges in our society. It's absolutely not true until we eliminate racism, and it rears itself in the care experiences of Black women, despite who we are and what we've achieved or how many assets we possess. And there's great activity, there's great research looking at this. We're talking about this in ways we haven't talked about. Healthcare systems are beginning to confront this issue. In Dane County, we work very closely with the Dane County Health Council, which is a consortium of our 4 major health systems, in addition to our federally qualified healthcare center, our public health center, our school district, and our human services department, naming these inequities, acknowledging how they play out in healthcare systems, acknowledging how it's linked to other sectors, economic development, housing, employment, education, and bringing folks to the table to name, frame, and then call to action how we begin to dismantle those systems and structures that leave us in this positioning where we continue to recycle the same inequities. And that's very promising work. But it takes naming. I really appreciated what Kevin offered and what Theresa offered in terms of what healthcare systems are doing in other areas of our state, naming racism, acknowledging its impact within systems, building relationships with communities that are authentic, and identifying those breakdowns, those holes and those gaps in our care system, and the philosophy and the beliefs that drive healthcare, looking at bias, looking at cultural competence, looking at workforce development, and in the meantime, doing all the things within the existing set of circumstances to make them equitable while we work on this bigger structural systemic shift. I like to say we have an opportunity right now in Wisconsin, and we have to take it. This next decade is really crucial. It's a time of reckoning in our state where we have an opportunity to really make major progress in revamping this whole story that we continuously talk about. I've sat on so many panels about this very topic each month, each year for the last 9 years that our organization has existed. I do believe we're coming to a place where more institutional partners, more sectors are beginning to acknowledge this very difficult truth and how racism impacts and plays itself out in our systems, in our institutions, in our decision-making, and our policy. And that we have an opportunity to really make a change in our state, but our level of courage and commitment is going to dictate how that plays out. But now is the time.
So what do you think is needed to keep this momentum going?
Oh my goodness. Honestly, the one thing that we often don't talk about enough is we need empowered communities, because it really is pressure from the people. It is pressure from the people most impacted. It is pressure from communities most impacted that really holds systems accountable. And we often skip over communities. We don't go to them to ask, what do you think? What do you need? What do you see as the solutions? We really, on the ground, community organizations on the ground, like the Foundation for Black Women's Wellness and others, I'm sure Laura's organization, are really invested in empowering and equipping everyday people with the knowledge and the tools and the access to elevate their voices, to position themselves as advocates, as leaders, to introduce them to decision-making tables. That is the missing element in our state to keep the pressure on for change. And we have to invest more in building the capacity of our communities to act in that way in their own interest.
And Laura, your organization certainly sees this at the ground community level. We've heard a lot about all the good things that are happening and are increasingly happening across the state amongst different systems, different organizations. What's being done though to coordinate all these efforts, make sure that we don't have too many duplicative efforts? Who's the quarterback? Who should be the quarterback of a lot of this movement? Laura, it's a big question, but what are your thoughts on that?
Yeah, it's a huge question, and I just want to acknowledge what Lisa had to say. This work, there is no such thing as a quarterback. There's many quarterbacks, and there is duplication right now. There just is. But empowering the communities, I want to just reiterate what Lisa had to say. Empowering the communities. There is not a one size fits all here. There just is not. So we need to listen to the needs of the communities. We need to empower community members to have positions of leadership and voices. And oftentimes there is not a cognizance of how the system works. And so for a federally qualified health center or community health center like us, for example, we are required to have 51% of our board members must be patients or users of our system, which is a beautiful setup. It really, truly is. And you get folks involved and engaged, and a lot of development needs to go on, because for the first time, maybe this is where they've had a voice and they've had power and they've been able to make decisions that impact their health and well-being, or the health and well-being of their region, because that's what health centers do. But there's not any one quarterback. So you have many quarterbacks, and all of the quarterbacks need to get together to represent one another. I go to the Wisconsin Farm Worker Coalition COVID Risk Mitigation Steering Committee that came together in April of 2020 and met diligently every week to talk about how to address the crisis that was facing our migrant seasonal egg workers in the state, and continued to meet every week until August of last year, and then went to biweekly, and only recently we went to monthly. Dedicated effort, multi-sector engagement. That has to continue. That momentum has to continue, and we can build on it to work on these other inequities that have now been uncovered. Have always been there, but we didn't talk about them, but have been uncovered, and we can continue that momentum. But it's not a one size fits all. We have to look locally, regionally, and then statewide. I mean, it's complicated, but we make it more complicated than it has to be. It really comes down to relationships and being willing to work together to come up with the solutions that are ready to be uncovered. We can do this.
Theresa, these efforts can cost a lot of money. It's likely that the post-pandemic period in healthcare is going to be, in addition, one focused on doing more to control healthcare costs. How sustainable are these efforts long-term for a health system?
Mm-hmm. That's a pretty broad question, Tim. I think there's many different efforts that are underway, but many of the things that we are talking about don't cost a lot. That relationship building, that connection to the community, that, ascertaining community voice as well. And certainly there are some programs that do. And we've been certainly finding grant opportunities to help support some of those things. So there's definitely a cost, but, as we're trying to get closer to patients and families, there are so many things that we can do that don't necessarily have a cost, that I think if we can even start there and then build programs on top of that, look for grant opportunities, and then those programs become more long-term. There are a program now going on with food insecurity, and one of our physicians saw the need right in the ED, and so he didn't want to wait. He just went ahead and put together a strategy with a group of other physicians that were concerned to give gift cards to kids. And so that's caused us now to have a whole program where we're providing food to families when they're coming in, and then trying to get them connected to resources more longer term. So that initial start of that program didn't cost a whole lot. Now, as we're building it, there's kind of some data there that supports why we need it, and then you can build upon there. So I think we just have to start where we are, meet people where they are, knowing that maybe in the long run there will be costs, but I think many of the things that we're talking about initially don't cost a lot. You just have to have the focus to get them going.
Kevin, does it make financial sense for insurance companies to continue to invest in things like housing?
Yeah, I think it does. And I think it also makes sense. And I want to just think of Theresa and her comments. The ability to identify opportunities where a good idea turns into a sustainable and scalable. It's no longer a pilot. It's now something that we do as a DNA, whether it be an insurance company or a provider. And I think one of the things, Tim, I think that's really important too, is you've got very different people on this panel from different sectors of both the community and the healthcare sector. And if there's one takeaway that I think is really important, is this concept of alignment, so that, and I agree with what Laura said, where every community is different, but the ability for us to take a step back, and particularly for us as an insurer, as a payer, to take a step back, look, how can we be a better convener and partner? How can we catalyze certain things through investments? But how do we make sure that those investments, and this is probably something that for me is really important. It goes all the way back to when I was at the state, which is if, you build trust by being there through the good times, and you build trust by being there when things all of a sudden may fall off the rails. And I think that's kind of the challenge as we look at some of these pilots, is making sure we're transparent with people that what's the game plan to move what's maybe a 5-person pilot, can that be scalable? Because as the former secretary used to say, it's always what they take away from you is what causes people to cause issues. It also causes distrust. And so for us, we want to be very pragmatic, and that's part of why we're not necessarily going to come with the ideas. We want to make sure that we are a tool to amplify good ideas. We want, like I said, we want to catalyze community partnerships. But I also want to make sure that we're aligning, that providers, payers, community, that we're not doing something under the rubric of this is really the best thing, and our community-based partners are saying, wait a minute, that's not what we need, that's not what we want, and you're actually hurting what our mission is and what our goal is. And it takes it takes a different approach from a leadership perspective, but also from just what we've been doing for 30 years. And as a payer, I think that's an opportunity for us to sit there and be different. And by being different, it means, yes, I would like my members to have access. I know that happens when the community gets better as a whole. And that's beneficial for all of us, whether it be in Medicaid, our seniors and Medicare, or anybody that's in any insurance product. The goal is just healthier communities.
Thank you, Kevin. So there's a lot of great work happening across the state. We've heard a lot about the great work that all your organizations are doing today. In the time we have left, though, and then that time is limited, so each panelist could talk about, one thing that your organization is not doing right now that it could do to advance progress in addressing health inequities. We have about 5 minutes left, so we got about a minute, maybe less than a minute for each panelist, as you know, is a tough task. But TR, let's start with you. What is one thing that the state is not doing right now that it could to advance progress in addressing health inequities?
Medicaid expansion would be great. That's certainly something that I think in the Department of Health Services and Wisconsin being in the minority of states who have not expanded Medicaid, particularly with the recent federal administration's incentive on Medicaid when it comes to ARPA dollars. And I know we only have a few minutes, but I'll say this, there's a narrative of scarcity that we accept as Americans, right? Combined with this concept of meritocracy, that you work hard to get what you want. So when you have this plane of this narrative of scarcity and this false narrative of meritocracy, what ends up happening is you believe that the cost of equity in the state should be a factor in deciding, when we don't often think, and especially at the federal level, that the Department of Defense should ever take a budget cut. And so I think when you're talking about what the state can do from this perspective is a revisioning of what we consider money well spent, time well spent, and even in the adjustments of, is this something that we should even be talking about cost in? Because that meritocracy combined with scarcity narrative doesn't align to the realities that people are living in and the realities of the decisions that we've made as a state and as a nation for those who we want to protect and do right by.
Thank you. Lisa, what more could your organization do?
Somehow I muted myself earlier. There's not a lot that we're not doing, but one thing that we realized we need to do more of is policy advocacy. So over this last year, we have taken up the necessary charge of building and broadening our policy voice. We are developing a policy blueprint for Black women's health in Wisconsin because there's never been one. There's never really been a roadmap to address these deep and persistent disparities in our state. And as a part of that, we're developing a health equity training institute to build up a coalition of Black women leaders and allies across our state, because that is the gap that has crippled us, is our ability to be present, to be advocates. This last budget cycle proved again, we don't have legislative alignment about what is best for every Wisconsinite. We had an opportunity in this last budget to really make a bold statement and bold action around health equity broadly, and it didn't pass our legislature again. That can't be our reality time and time again. So that policy advocacy and presence in that arena is where we are focusing more of our efforts right now.
Thanks, Lisa. Theresa, what more could Children's Wisconsin do to address health inequities?
Where we are working in certain or located in certain zip codes that may have different needs than maybe the majority of our clinics, is really looking at access to care and looking at hours and making those times even more available than they are right now as well, especially where we see that there's a significant gap. We know people are missing appointments for a variety of different reasons. So I think we could align better to meet those needs in those communities specifically.
Thanks. Kevin, what more could you guys do that you're not doing already to address this?
Yeah, I think again, we're doing it, but I think advocacy around how do we broaden the toolbox? How do we get providers that may, thinking about this last budget, doulas, community health workers, how do we continue to expand that? I think the other part that we're doing, but I think we can do better, is also when we make investments, moving away from the traditional grant type of investment, but looking at small business, small diverse businesses as a strategic anchor institutions in the community that then can be part of our larger portfolio of partners, so that it's not just what I'm doing today, but it's actually part of a larger game plan of making long-term investments in the community. I think we can do better on that, and it's a great opportunity for us here in Wisconsin.
Thanks, Laura. Like all these organizations, your organization is doing a lot of great work around this, but what more can you do to address health inequities?
We can make sure that folks know what we do in the communities that we're in, and that we are here for them, so that they can get the services. Many times, because of our name, people think we're only for a particular group, but we are here for everyone. We can make sure that there are oversight and advocacy groups in each and every area that we're serving that are providing feedback and guidance in addition to our board of directors. And we can continue the work that we're doing now. I wish I worked with this group every day, because it's very invigorating, and it gives me great hope in terms of our ability to continue the work. We just need to carry on. We cannot get lost in the enormity of the task in front of us. We need to continue on.
Well, thank you guys. This has been a really great discussion. I appreciate you all taking some of your valuable time with us today. Thanks to all of you for tuning in. Thanks to our generous sponsors for making this great discussion possible.